So, really delighted to have you officially here. Ellie is one of our center affiliates, and this is where I get to try to give a quick bio on you. But we've been working together now for a number of years, and I think having a lot of fun, usually. Usually having a lot of fun. But Ellie's background is actually in development biology, brain studies, right? Brain development, right? Stuff I don't understand. But has been able to translate that background and that kind of systems thinking into her work now as the CEO of Talus Analytics. And I'm gonna actually, like, instead of me trying to say what you do, I'm gonna let you say what you do.
Okay.
If that works.
Absolutely.
So, and also feel free to just like sit if you want to, whatever you're more comfortable. We're small today.
Move.
I know.
So, right. So I'm Ellie Graeden. I run Talus Analytics now, partly because it turns out what we do fits in this funny niche in between a lot of different fields. And so the academics didn't quite know what to do with me, and having a doctorate in wet bench biology means that as I was trying to get into policy or starting to think about complex systems and putting some math to complex systems, these weren't things that fit together well. And so nobody really had a clean home for what I do and how I think about the world. So I created my own sandbox to be able to go and solve these sorts of really interesting problems that sit really fundamentally at the nexus between the science and the computational data that are coming out of modeling systems and so forth, typically in some sort of risk context. Merge that in with the policy. So how do you develop a structure, an organizational structure to govern? And then how do you actually get stuff done at the end of the day? Sort of operational, practical, tactical execution of what has to get done on the ground. This is all, so we apply this in a whole range of different places. We've done this with FEMA for hurricanes and earthquakes and nuclear detonations. But at the heart of it, I've always been a biologist, and I really enjoy biology. I like human systems. I find them really interesting because they're messy. And so you can't just stick them in the box and expect them to do the same thing every time. I've spent a lot of time working with engineers. We get very frustrated with human systems because humans don't need spec. Engineers want spec. They want to know exactly what they're going to build. They want it at a very specific tolerance, and they want it to work every single time the same way. And as we all know, humans don't do that. So what we spend a lot of time doing is thinking about how we take these big, messy systems, apply data to it, put that in the context of a broader system, and then communicate it back to the types of leadership who are going to be making the decisions that actually restructure those systems around the data. So we do a lot of translation between different fields, and what I'm going to be talking about today is a series of 3 different projects that really compose a sort of suite that we've been working on with CDC, the National Center of Influenza and Respiratory Diseases. This is primarily under Dr. Anita Patel, but also Dr. Cindy Leinbaum. And some of this is really quite new, so you'll be getting the first glimpse. So I wanted to start with a sort of base setting. We all know what flu is, but the really key characteristics that are going to become relevant for what I'm going to show you today and walk through today are, 1, a reminder that yes, we have these seasonal outbreaks, but they're started by new strains each year. So we always have to remember that we don't necessarily know what we're looking at, and we don't know until people start getting sick. We're always taking a best guess when we're generating a vaccine, and we get as close as we can. That means, though, that not only do we have a new vaccine, but we also have new public health response requirements. That becomes particularly true when we start thinking about ways to get larger scale outbreaks, whether this is a pandemic strain, meaning either a strain that is outside the seasonal cadence, or simply a fundamentally different strain that has a much larger relative impact on the population. We can think about that as caused by biosecurity threats, thinking about the sorts of research that's being done in labs where they're looking at gain of function, things like the work on H5N1 that caused a bit of turmoil a few years ago, we'll phrase it that way. Or, as we've all done, such a look at 1918 with the 100-year anniversary of that, in this last year, we're all very familiar with the sort of scale and scope that we certainly did see previously, and we as public health experts believe certainly could happen again, or there's some potential for that. So at the core of it, though, both preparing and responding to these sorts of events requires really close collaboration and communication between those at the local scale who are seeing the patients, treating the patients, needing to actually work with the population, those at the state who are then aggregating and helping coordinate among their local communities, particularly distributing resources, for example, between rural areas that may not have the ability to do that type response, and larger level, and then the federal public health response. So what we spend a lot of time thinking about, and what we're really worried about here, this is a relatively new framework coming out of CDC, where they're starting to think about how you position different types of strains along axes, compared to both transmissibility and severity. So what we're really worried about here is transmissibility, so how easily the disease spreads. This is a relative scale here from 1 to 5. And severity, which is really at the core of it looking at intensity. CDC has a specific definition of severity that I'll show you in a second. And then there's this core question of uncertainty. Which version are we going to get? How do we recognize it? How quickly can we assess it? What you can see here is our standard seasonal range is down in this lower quadrant. You can see that 2014 to 15 was a pretty bad year. It was relatively severe as things go. Last year's was actually the first seasonal strain that's fallen into this high severity bin for all population types. So it starts giving you a sense for something that we've seen, getting a sense for what that span is or what that range is. The 1918 pandemic is really where we anchor up in this upper right-hand corner for severity and transmissibility.
So for those of us who have really bad eyesight, that's from an MMWR?
It is, and I'm happy to share that. So this is all published in MMWR. The number is RR6601.
Hold on. MMWR. Say it again.
Sorry. RR.
Yep.
6601.
Thank you.
Absolutely. So CDC's definition of severity moves from these sorts of broader characteristics of the virus, and we start thinking about what the impacts are. And this is a useful transition, right? This is always the case. It's not just what is the event itself, it's what are the impacts of it, how do we measure it, what do we see? In practice, it's percentage of visits to outpatient clinics. So many people actually go see the doctor. Most of us have had the flu at one point or another. We very often did not go see the doctor. So those who do start to tell us how severe it is. Rates of influenza-associated hospitalizations, that makes a lot of sense, and then the percentage of deaths, particularly caused by pneumonia or secondary infections. As we start thinking from a public health context about what we can do about these scenarios, what do we do about the flu? If this dark purple is your base case for the outbreak, our focus is twofold. One is to slow the acceleration of the number of cases. How do you slow down transmission? And how do you, therefore, dampen, both by slowing so that you have fewer people infecting each other, but then also dampening the effect so that they are not as likely to get sick once they do get exposed. So this can be vaccinations, antivirals, and a whole series of other interventions, whether that's social distancing and so on. This can also just be making sure that you're getting the word out so that people don't go to work once they're sick. Importantly, in this particular case, I want to highlight that, because it'll come up later, these antivirals really do need to be given shortly after symptoms arise. That's partly because in most cases, the primary goal of that antiviral is actually to reduce transmissibility, not to help the person who's sick. So keeping them from passing that virus on is the critical component of that antiviral. So, okay, right. So we have a good baseline for what we're looking at here. We know what we're worried about. What do we actually need to do? What can we do? So we have a sort of base case of outbreak with the first case identified, the outbreak spreading. We see a healthcare system that starts getting strained, right? And especially for these more severe outbreaks. you can peak pretty high, and this ongoing response and recovery period actually lasts for quite some time. Over the course of that time, we need to be conducting ongoing surveillance and identifying the strain, vaccinating the population whenever possible. You'll notice that there's a dotted line here. Very often, these vaccines may not be available right when the outbreaks begins. It might be up front, more like a seasonal strain where we've taken that guess 6 months before and gotten vaccine generated early. But again, it's a guess. And if it's a brand new strain, the bare minimum is a 6-month turnaround time to get the first vaccine into the population. So there can be a pretty solid delay there. There's a whole round then within response where we need to be thinking about prioritizing and distributing resources. This is a logistics component that we as public health folk actually don't often spend probably enough time thinking about the sort of practical aspects of logistics. Who needs what types of supplies where? How do you do MOUs for sharing personnel, helping nurses operate in more than one state? Actually just physically getting supplies onto planes and sent to the right place at the right time where you're not then draining supplies at some place that you'll need them later. These are the kinds of things that when we start talking about large-scale natural disaster is just part of the ops cadence. It's a little clunkier sometimes for public health. It's just not part of the way that we think about it. We also then need to manage surge capacity. What we're really talking about here is that if we have a whole lot of patients coming in, we want to make sure that those patients who need the most critical care can get it. How do we make sure that that's happening? And then, again, continuing to monitor and maintain that response. That's the other thing. We also have this tendency to have this big push up front. Everybody gets really excited. They go in full force. And then our attention starts to slide. And so that's when we can then see resurgences and outbreaks. So thinking specifically about what CDC does, and really can do, because there's a fair bit that we can do at the federal level, there's actually a fair bit that we can't. So at the federal scale, CDC can't go in and care for patients. CDC can't go in and tell the states or the locals how to care for patients or how to distribute resources, at least not until they're asked to help. So useful reminder that they don't get to just go in, guns a-blazing, and help. They can do a whole lot of information aggregation and dissemination. They can do medical countermeasure management. Now I'm using that phrase carefully. They can't manage the supply chain, but they can help unstick it. They can make phone calls. They can help talk to pharmaceuticals about what's going to be needed when and where and jumpstart pieces. They can certainly be coordinating preparedness and response activities, and they can facilitate a lot of communication. And this is one of the most important components. Once they pull in all this information, they can actually get that back out, both to partners, but then also to the public. So in that light, they need an integrated source of information about what's going on across the country. There are already a lot of data that are being collected at the local level. Care providers collect a huge amount of data. As we all know, a lot of that is in EMRs, and those electronic medical records are sensitive, right? We can't just share all of those data. We also track influenza-like illness. Now, ILI is because it is a designation specifically caused or generated because we very often don't get confirmatory tests that it's flu. So we need a catch-all to say, well, what do we really think the caseload is? And it's probably dramatically higher than those who actually have confirmed cases. So that's our catch-all, but it's a mandatory reporting. So as soon as somebody does have a confirmatory test, that gets collected and sent up and aggregated. We also then start getting phone calls, emails, and alerts from providers. That matters because it's ad hoc. What I'm trying to highlight here is that these are large catch-all bins that are not necessarily standardized and may well come in a format that is not easily aggregated. This is not a computer system. This is not a single API for data transfer. This is not designed to be aggregate from everywhere across the country. It's all going to be pieced together. So how are we starting to tackle this? we have a suite of 3 different tools. We have a vaccination dashboard, we have Health Pulse, and we have Flu on Call. At the core of this, we're going from preparedness to some indication around situational awareness, what's actually going on, how bad is the outbreak, who's starting to have trouble, and then what do we do about it, how can we actually manage surge. So I'm about to walk through those 3 in much more detail.
And those are all ongoing CDC programs that are managed out of the influenza branch?
That's correct.
We may get to this, but what about social media sources? Are you going to get to that? In terms
So
of
we are not collecting it. There are ways to do it. Let's get there.
Yeah.
So the vaccination dashboard is where I'm going to start. This is really in thinking through how we monitor preparedness. So this is a program, the vaccination group has been stood up and active, very active, within CDC for a long time. This is all in the National Center for Influenza and Respiratory Diseases. So the primary focus is flu. You can certainly imagine using these sorts of corollary systems for other large-scale events. You swap out the disease and you can't get there. The whole goal here, right, when you be reducing the cases, you want to be distributing prior to as well as during the event. And it's most effective when the vaccination coverage is high in the population, so that you can actually trigger herd immunity. And at the core of it, if you want to then be targeting your efforts, so you need to know when and who has been vaccinated and where. And preferably, you would know that relative to your caseload for whatever the outbreak is. So we already know that we have a lot of data sources. This is one of these lovely cases where we actually have data. This often does not happen. However, we're looking at a minimum of 5 different sources, each of which has its own specific way of collecting those data, reporting those data, and having data for which they are better or worse. So, for example, NIS flu only does children. So we have really good data for those who are 2 years to 18 years, but they don't do adults. And there are a fair number of other sources that, because of the way they're collected and because of who's giving the vaccine, if you only look at, for example, pharmacy providers of vaccine, you actually underrepresent children because many of them are getting it from their primary care physicians. So if you're only looking at those pharmacy doses, then you end up overrepresenting the adult population. So we're needing to comb together all of these different sources, figure out which sources are best for which subpopulations overlap with the other subpopulations that we're looking at, and how do you integrate and aggregate those data together, which is at the core of it, a data integration problem or a data alignment problem. So what we're doing here is really working on, like I said, aligning and integrating those data, but then also visualizing it. So one of the things that we have learned as data scientists in this field is that if you don't have an effective way of communicating it, it doesn't matter how good your data work is, nobody uses it. It doesn't make a gut level impact, and you can't put it on a slide for your briefing. And it turns out having a pretty picture to put on a slide for a briefing is one of the most single most useful things you can do to get something communicated to leadership. I'm not dissimilar. I like a pretty picture just as well as anybody else, and it turns out the really clean data visualization makes it make sense and makes it meaningful and real in a way that it's very hard to communicate with a whole series of bullets. So that's what we've then done here as well. At the core, the other piece that's really important is the contextual information. What happens a lot is that when we start talking about data, what ends up happening, we hear things like 35% coverage. Relative to what? For which populations? Where? How does that compare to last year? How does that compare to last week? Are we getting better or are we getting worse? Right? So you can even think about this in the context of power outages. You may have the same number. In fact, you do have the same number, right? If you're going up and coming back down the other side, you hit it twice. But on one side of this curve, you do something very different in terms of response activity than on the other side of the curve. So if all you're looking at is your raw number, you've learned nothing. Same thing's true in an outbreak. So what we've done here, and this is just a couple of quick snapshots of a draft dashboard. We're very early in this particular project, so I just wanted to give you a teaser here. But we can then map coverage rates. So this is percentage of the total population across the US. You can then filter by the subpopulation you're interested in, whether that's children, adults, older adults. Some anomalies in the data. It turns out you can't do subpopulations for age and by race ethnicity. It's an either or because we don't have the breakdowns for the different age brackets in the race ethnicity data. So it's always, these are the sorts of issues where we want to be able to give somebody the access to the most information we possibly can, but there are always some caveats. But what we do is always make sure that we're referencing a season to date, right? And showing whether this is above or below where we were in the season last year by this time. These are all notional data. All of the data I'm going to be showing you in this deck are all notional. But we can actually get to total doses administered. This is just a pop-up for Georgia, but there's a national overview as well. And then we can double click and get into the details. What we've also done is represented these data relative to the influenza-like activity across the US. So this is all coming in from ILINet. What we've done is taken the graded scale so you can start to get a sense for whether you're getting high vaccination coverage rates in the places where you're seeing flu. There are differential rates for who's getting sick and when in the season. So are we actually seeing uptake of the vaccine in the same places that we're seeing caseload? Where you really want to be looking at these areas where you have a differential, where you have high caseload, low vaccination rates. That's where you really want to get your public messaging up for vaccines. This changes what CDC does and how they focus or prioritize their efforts. These sorts of, they're simple representations, but it turns out that if you can give these sorts of comparators, now all of a sudden you have an action you can take. Yeah,
sorry.
Please.
One question. When you're identifying data challenges, like what you just said, is that information that is also being fed back, like to CDC? Because that's also potentially a type of thing that CDC can, or HHS writ large can try to bring the stakeholders together. So I was just wondering if there's the product, but there's also the identifying where there's challenges with data.
Yes. So working backwards, we are not an active software product company. What we do is build some user interfaces and some dashboards to communicate it. We are at the core of it data researchers and data architects. So one of the most important things that we do is write all the documentation. So we have a whole series of methods, reports that go back to CDC and any of the people that we work with, or any of the teams we work with, to document what data do we have. So we build out a data inventory, which categorizes all of the sources. We then map out a data dictionary, which defines each individual element of data or metadata. It gives it its tag. We show what the refresh frequency is. How often are we getting those data? We show what are the subpopulations. We show where we have it, uncertainty, certainly resolution, whether that's temporal, we do temporal and spatial typically. And then we can map out exactly how we get those data. So are we getting it in a PDF that we then have to hand jam ourselves? Are we getting an Excel file dropped into a Dropbox folder, which happens more often than not? Or do we actually have a case where we can pull those data automatically through an API or some other cloud-based source? So we document all of that, and then we get all of those data back. Now what we've learned, and you'll see this a lot in the Health Pulse data, we actually built the system around what questions are being asked, and then work backward into the data, so that we really define the core requirements, and then we go searching. What that allows us to do is actually articulate the optimal case. And that's something that doesn't always happen. If you start with what you have, you don't always define what you really want. So this allows us to more clearly articulate that gap while meeting the ask with whatever data we have. So we certainly have that conversation in it, but I think it's the most important thing of what we do, so I'm really glad you asked. So in this particular case, again, and this is there's sort of two parallel stories here, right? There's this sort of, okay, what do we do on this public health side? Well, we need to vaccinate, we need to prepare, we need to get ahead of it. But then there's this other story about what are all these different ways that we end up working with the data. Data science is this big, enormous bin, and everybody starts to think that it's just working in R, in an Excel spreadsheet, or in a CSV. And it turns out that the vast majority of it is figuring out what the data are and how we align it, how we think about it, how we make those data work together in a way that tells a coherent and accurate story. As any data scientist will tell you, the hardest part of our job is data cleaning, but even that gets poorly defined and is ill-defined. There are lots of different ways that you have to clean data. This is just one really good example of it. So it's aligning and integrating across demographic groups, whether age, race, ethnicity, special populations, including pregnancy. One of the big issues here is figuring out what your baseline is. We actually don't have a good denominator for a lot of these things. We're going back to census data for a lot of it. But that's a little suboptimal when we're looking at something like public health. And certainly when you start looking at subpopulations, it turns out a lot of these data may only be available at the state level, not at the county scale. Well, there's not a whole lot we can do across an entire state for public health response. And in fact, some of the data are only available
Depends on the
nationally. Depends on the state. But having grown up in Idaho, a very large one that is very disparate and doesn't have a whole lot of money for public health implementation, let me tell you, you do things very differently in different regions across the state. And what is happening in the north is very, very different from what happens in the south. We also need to be looking over time, right? So this is this temporal axis ends up being one of our most important, but it's amazing how often you don't get trend analysis when you're starting to look at data. So that's the real key here. That's both looking at it for this season, but again, also that comparator against previous seasons, which gives us a marker for how we're doing. Again, by state and national, or by state and nationally. And then relatively ILI activity, and then the vaccine distribution data. So we actually start looking at supply and demand here as well from the pharmaceutical supply chain. And all of these things start to, again, get us to these core things that CDC can actually do to respond. Okay, so we've set this up. We've started vaccinating the population. We're trying to get ahead of the curve here. Now the outbreak is happening. How do we know? We have the ILI activity coming in, but how do we know if it's a year like this year, when everybody's just kind of keeping up? Not a big deal, not a really bad strain, versus last year, when all of a sudden what happened was sometime around January, CDC started getting phone calls that they had patients stacking up in cafeterias in hospitals, had patients stacking up in some cases in parking lots. When are we starting to get those sorts of effects? How do we differentiate? So there, for a long time, was a program called HaveBed that was maintained by HHS Asper, and it looked at hospital bed capacity. So how many beds are full? What that allowed us to do was to start thinking about, one, where we would expect impacts versus where we're actually seeing impacts. So are we seeing low hospital bed counts where we're seeing high caseload? But we also need to then, and that starts to tell us what that comparison is going to show us. It allows us to start thinking about where our expectations are not lining up and what that might mean about what's happening. Now, HaveBed is defunct. It is no longer. Depending on where you look at it on the web, they put up cobwebs. And the real issue with HaveBed, when we started looking at this problem, was that you have no baseline. We actually don't know how many beds either one, they normally are using, how many beds they have to begin with, what type of beds those are, whether those beds are staffed, right? All of these things that start to adjust what that bed does for you one way or another. A cot in a hallway does a lot less for you than an ICU, a fully staffed ICU bed. So we started looking at other places we might be able to get these data. We know that HaveBed's defunct. We know that we need some good way to calculate what normal capacity is and what our differential capacity is during the outbreak. And what does that tell us about who needs help, where, and when, and for what? So we sat down and we talked to people. Other things that are not enough data people do is actually sit down and talk to people who are using the data, collecting the data, or making decisions on the basis of it. These are experts in the field. They may not be data people, but they know what they need to know. They know what decisions they're making. They know where they go to get that information. So we talked with a number of folks across CDC, but we also spoke with state health departments and hospitals. We're in collaboration with ASTO on this project. It's been really helpful because they know these hospitals. They know the folks at the state level, and we were able to get on the phone with them. What we learned was that largely, especially in the more funded states, and in some other less well-funded states but that are doing really good work, Louisiana is a good example, there are systems in place for data collection. They have WebEOC, they have other third-party systems where they're doing data collection. But the reality is they're neither connected nor consistent, and they're certainly not connected state to state. And when I say that they're not consistent, the biggest problem is that the data that are coming into the systems are sent to the systems when somebody's in crisis. So if you're just going through your normal day at your hospital, and things are just kind of chugging along, you don't think to send your data out to the state. You don't need any help. You don't really care what's going on. Things are fine. It's not until you start to struggle that you start to ask for help, or that you start to even tell anybody what's going on. The challenge with that is that at the state level or the federal level, you don't have a constant signal. There is no baseline here. You can't figure out how many beds they normally have full, because it's not a number that they bother to report. So that's the problem we were trying to solve. What data can we get? Are we consistently seeing in these systems that then can be shared broadly? Because that's the other issue. You can't do caseload. You can't do cases, right? Those are private data. They're sensitive. You have to clean HIPAA, clean any of the HIPAA-sensitive data. These are not the kind of quick share things. You certainly can't email it. And then, again, this consistent baseline is the challenge. So we started thinking about what that could possibly be. And what we came to was an alert system. So it turns out most of these systems collect a lot of really granular data on, when I say these systems, the state level systems collect a lot of granular data on what is happening at the different locations. But it turns out what we really need to know is just who's thrown a red flag? Who raised their hand and said, I need help? And if they raised their hand and said, I need help, what do they need help? Are they supplies? Are they running out of ventilators? Are they running out of antiviral or vaccine? Is it that they're having trouble getting folks to show up to work, right? Either because the nurses are sick or because the nurses' children are sick. And then how do you know, or is it because they're actually having to change their standards of care, right? So when you're actually starting to see standard of care shifts in the strategies for standards of care, then you can start to gauge the challenge.
But there's push and pull there, right? Like, why am I going to if I don't think anyone's going to come to my aid, why am I going to bother to raise the red flag?
So it turns out, at least where we were seeing it, people will send it out. What we see are text message systems and emails. And that's the most consistent data that are sent out when somebody is struggling. It's not an absolute indicator. You're right. There are many cases where it doesn't happen, but what we know is that the baseline for this one is 0. That's the beauty of the system. If you're not sending an alert, then you're fine. So we can anchor our baseline at 0 and then just say any signal above 0 means we have some issue. And you have to remember, right, in this particular case, we otherwise had 0 ability to know who's struggling where or not.
Yeah, but I mean, let me ask though. I mean, it's just to get my head around that. So I'm a facility and my nurses have all called in sick, and I send out an alert. What happens? Is CDC really going to parachute in with clinical care?
So no, but CDC does need to know. So what CDC can do is, for example, if supply, so for example, what can happen, so this is what we were showing during an exercise. So The exercise was bioterror attack, so that's why you're seeing it spotty around the country. It was all coming in via plane. But what allows you to do is say, okay, let's say you're getting a bunch of supply alerts. If you have a large number of supply alerts in a place where you're seeing a lot of cases, that makes good sense. You're probably actually just starting to run out of things. You can start to then trigger mutual aid agreements. You can start to do, supplies are actually relatively easy as things go, or can be.
But again, I'm struggling with even supplies too, because if I'm running a private hospital system and I have my own supply network and my own supply chain and contract with private industry for that, why would the alert to the federal government matter?
Well, mostly because the federal government needs to know, because they do get asked to do things like call pharmaceuticals or call what the federal government can do is unstick things, right?
But is this only sending an alert to the federal government, or is it an alert in the state system that's a question?
So these alerts, this is aggregating from the state system.
That's what I understood, okay.
So these alerts,
alert
they're
to
sending
the
the
state.
alert because they're hoping they can get help. It's a way of generating a call, right? And a lot of these hospitals are actually sharing patients. They're doing diversions, other hospitals. They're pretty well coordinated, and the State Hospital Association often does actually have some leverage when it comes to supply chain and managing supply chain, helping those things. Like I said, we also have mutual aid agreements, and when the alerts are more like, hey, we're out of power, you can also then start to trigger things like a generator drop, and then making sure that you have fuel, right? So it's what we hear from talking to the hospitals is that they actually want to have somebody to share the information with. They want it communicated, and they certainly want to know. The states want to know what is happening outside of their state, but also within their state. And then CDC needs the situational awareness, because what ends up happening is that if everything's fine, it's fine, and then you hit these crisis points, and they don't know when those triggers need to be generated. If you're going to turn on the strategic national stockpile because you've suddenly hit a pandemic threshold, you need to know when that's going to be. You need to know, when is my entire map going red? So that's really what we're trying to get to here. Or, for example, when you need to trigger an EUA for an early vaccine because we just need to get something out.
No, and I totally understand why you want that information, right? And what you need for it. I'm still struggling a little bit with, like, if I'm a provider on the ground, like, why am I going to take time away from my schedule unless I think I'm going to get something out of it?
What we know is they do. What we know is that these alerts are already being sent to the state.
And if it's at the state level, that makes more sense.
Yep. But the cool part is,
tied to their hospital preparedness funds?
yeah, they're really good things to push on here once we get a system in place, because then you can start to think about how you can use these data consistently. And it is explicitly spotty. What we're really focusing on right now are just some sentinel hospitals that we can get on board to do this. Right,
That's different, yeah.
And then we can go out to specific hospitals who are trying to generate relationships or build relationships with CDC. There are lots of reasons that is incentivized. Mm-hmm. But that's where we're focused on this right now. These are all notional right now. We have indication that these data are there. These are the only data that we could find. This is a case where instead of having more sources than we could deal with and actually starting to weed them out based on the quality of the data, we're trying to just figure out what we can get consistently that will actually give us something above, like I said, a consistent baseline. What you can imagine is if you, for example, have a large number of supply chain alerts or supply alerts in areas where there are low caseloads, and that starts to be consistent, that's also indicative of a supply chain issue instead of just a caseload issue, right? So these types of information, especially when then layered on, can really start to drive where you focus those response efforts. We can then dive in and look at that at the state level. So again, facilities with any alerts, and then marking it down to supply chain alerts, provider alerts, strategies of care alerts. These do not add to 25 because you can imagine that a single hospital can in fact send out more than one type of alert, and this happens. What we also see is that when a hospital is in true crisis, you get exactly one alert. Interestingly, if you start getting more, it suggests that they are less in crisis than places where there are fewer alerts. For exactly what you were describing, who's the nurse who has time to sit down at the computer and send the alert? Also really importantly though, turns out these alerts are already going out through text message and email. What that means is they are fundamentally not sensitive. They can be shared. If you can send it over text or email, that means they aren't worried about data sharing for that. And they're not sending patient level data, they're not sending HIPAA data. So it means that you can get these data much more consistently, and CDC doesn't have to worry about aggregating them because again, they're not sensitive. Alerts over time, percent of facilities with alerts, number of facilities with alerts. These are the kinds of things that actually help you start to figure out which hospital to call first. And this is something that happens a lot during emergency management at large. You find out exactly who is struggling, and you actually do. The folks at the federal scale make a phone call to the head of that hospital to ask if there's anything they can do. So it ends up being a push system as well as a pull system. We find out that you're struggling, and we don't even necessarily need to know a lot about what you need, but we know which hospital administrator to call to ask. And just narrowing that field helps a lot. The other is that if we happen to know it's all in the Houston area, that tells us something fundamentally different than if you're getting alerts across the whole state. It may just be localized. So again, who has sent alerts for how long? We're doing things like pulling in the data from the hospital databases, so we actually find out exactly what that hospital is. There is information on facility size, so you can start to get a sense for, are these all large hospitals, small hospitals, or otherwise? How many days have they had with alerts? What is the time frame? Right, and all of this ends up being really useful because now you have the context you need all in one place. So you can start to get a sense for where the concern is and how great that concern is for whom. So again, the real challenge here is data collection. And that's been the challenge. There really are no data. They're tracked inconsistently. And without denominators, how do you know if something's happening? So now we're moving into what is in fact the most robust of these systems and is fully launched, not fully operational, which is Flu on Call. It has not been activated yet, but it is now to a point where it could be. The goal here, and the goal of the Flu on Call system is once you get strain on your healthcare system, and you know that there is strain on your healthcare system, and you know that your primary care physicians and your ERs are starting to get overloaded, how do you make sure in a large-scale event that the people who are actually going into respiratory distress are the ones who get their emergency care? That won't happen if a bunch of folks who are just worried about getting that vaccine or need a prescription that can be filled without going to their primary care physician, something where they don't actually need to see anybody. How do you keep them out of those healthcare providers so that the people who really need it can get it? So the goal here is to lessen the burden on the healthcare systems, answer general questions, triage patients, and provide alternatives to face-to-face providers, including phone, prescription by phone. And there is a mechanism for this now, which is really nice. You can now do this. You can do it across states, at least under an EUA. And then you can actually improve access to antivirals, which particularly given that there's this very tight time constraint for when those are useful, it becomes really critical. If you can get it to them 6 hours earlier, you've actually made a big difference. So, one, it's activated only in emergency. This is not an ongoing system. It gets turned on. There's a number that then is distributed nationally. That's then going out via number and also now a website. It started out as a call center based system. We're thankfully now moving to the web. It's okay, it's federal government. Sometimes it can take a few years to catch up, but we're there now. And the goal here, again, is the primary goal is to provide information for those who need it, and then medical advice if needed. So it's a nurse triage line. What happens is it comes into an information specialist who says, are you sick or not? Are you sick or caring for someone who is sick? If not, you go to an information specialist who can answer any questions. If you are, then you get triaged to a nurse line. This is now getting to the system itself. What we show are the calls coming in. Again, this is a notional data set that's designed to show how the visuals work. This is hopefully not the condition on the ground. These are phone calls coming in. What we've done here is sized by the total number of calls that are coming in this week or today relative to yesterday or the day before. So the color code says, is it getting better or is it getting worse? Do we have more calls or fewer calls? So just some really quick signals to say, okay, we have a lot coming in California and those are new. So how do we start to signal immediately and visually where the crisis is happening? Who is using the system? Again, basic demographics matter a lot. Who's calling in? Are we actually, and you can then toggle between the who is sick versus who's calling. So what we see a lot are that women between the ages of 25 and 40 are the primary callers for these sorts of systems. Not surprisingly, they're doing a lot of the care, not just for themselves, but for their families and for their parents. So who calls, but then who is sick? This is where you can start to align this with some of the epidemiology coming out and both see if your system is getting utility by the groups that are getting hit the hardest by your flu and by the caseload, but also it can then be used to validate or cross-check against the flu data. These are all coming in real time. Most of the flu data that we have has a 2-week lag. So it may be able to provide us some sort of indication of where the event might be headed. Pregnancy status and gender, but also what are they needing? So this is where we can start to break down even just the top frequently asked questions, where we can start to figure out what are the medical professionals asking of the system, and therefore what guidance needs to go out from CDC to help drive or to more effectively message to those who are actually providing that care. We can then start breaking it down for who's calling. So again, these are all tools that are designed to have a dual purpose. We want to be assessing how the program itself is working, who's calling, are they getting the help they need, what are they calling for, but then also how does that line up to the outbreak that's happening. And then provide access to antivirals by phone. Again, this is prescriptions. But this is really nice because we can start to tie this into things like Flu Vax Finder. And we can start to actually figure out which pharmacies still have supply and where we should be sending people. And then we can actually, this is, I know, a little hard to see, but these bright green boxes indicate who's being sent to the ER. So we can actually start to look at severity of case. Where are we seeing the most patients getting sent to the ER, and are we seeing a differential in that severity compared to the caseload?
Who's being advised to go to the ER, who actually shows up at the ER? Who's being advised,
which at least gives us some. And again, this is, as with most of the data, it's imperfect. These are not the optimal data here. But the reality is we otherwise have no idea. So it gives us some indication. So the data challenge here was really in common definitions and structures. So the fascinating thing is when we started talking to the call center folks, we said, well, we want to know how long somebody's on hold. So they gave us a number. And then we started parsing through the data and looking at the breakdowns, and it turns out there are 4 different definitions of what hold means. So it turns out your epidemiologists don't speak the same language that your call center folk do, and they probably don't speak the same language as their state or local public health implementer. So how do we actually figure out what your definition is? How do you even know to ask that question? I can tell you it took us almost 12 months to figure out that we needed to ask what the definition of hold was. It turns out, by the way, that call also has multiple definitions. Is it when somebody picks up the phone? Is it when it rings through? Is it when somebody else picks it up on the other end? Do they actually have to engage? Right? So these are the sorts of things that, let me tell you, these were not the data challenges we thought we were going to be dealing with in this system. But these are the data systems these are the data challenges that end up breaking a system if you haven't gone through and figured it out. You need a common picture, and you need to be tracking individuals even if they start in one place and go to another. So how do you actually do these transfer systems between these older call center systems that were not originally ever designed to be hooked up to the web. We now are letting people come into the web and then call, but then when do they drop off the call and go back to the web because they've decided the wait time is too long? How do we track that flow? How do we know who's getting help how? And how do we make sure that they're getting consistent help? So that's been the big challenge here. There's a whole different set of issues around e-prescriptions. Now you are talking about some of these systems being HIPAA compliant. That means that we need to be doing then data cleansing from all of the privacy data before they can be aggregated or communicated, right? And now all of a sudden, this becomes this incredibly complex data system on the back end. Yeah.
So, I think this is a really nice system. I'm curious in terms of, you talked at the beginning some of the potential for leveraging a system like this for other threats should they occur. It seems, just from what you've said, one of the big things would be making sure people on the help side were familiar with whatever the agent issue is. But what's your take on what some of the steps would need to be, the challenges, those sorts of things, if you were to, if there was another anthrax thing? Because I know, there's a lot of the worried well and those sorts of things. And so this sort of system is nice because you can start to tackle some of that, where I know a big issue's been all of a sudden everybody's going to flood the emergency rooms, and so there's a lot of opportunity. But from your experience of, as you said, like having to live through what the data challenges are, what's your sense of, big picture where some of that attention would need to be, where the data challenges might be, or in terms of if you were going to shift to different agents?
Right. So I think a few things that come to mind.
Yeah.
One is you're going to be talking, especially if you're talking about something like an anthrax attack, you're talking about a very localized event.
Right.
So this distribution across the country for who can be taking phone calls is really important, even though the phone calls are likely to all be coming in from the same area. So the phone call and web-based system is really critical there, because there is a mechanism for distribution in a way that if you're trying to actually get somebody in to see somebody, you can't do. The other challenges are going to be that for something like anthrax, many, many, many more people are going to be more severely ill. So your proportion of severe ill go up. So there's only a certain amount of surge that you're going to be able to manage there. For the information and the worried well, I think that's your biggest benefit. The key there is going to be a fact sheet that can get sent to the folks who are taking in those information calls. And what we really would probably want is a series of templates behind the scenes where we've mocked up those sheets already and can distribute via a web version. The things that we've already done within the system to allow this to be flexible are just little things like, where we have our antiviral or medical countermeasure implementation components, we haven't hard-coded those. Those are all so that you can actually swap them in and out, depending on what's available and what the different indications of use are. That allows us to move more quickly where the guidance to change. You would also need different sorts of emergency use authorization, not just for the drugs themselves or the medical countermeasures themselves, but also for who's allowed to administer, who's allowed to prescribe. It's one thing to prescribe a really well-known antiviral that's been fully vetted and already has FDA approval for most things. It's another thing if you're using any sort of newer treatment or off-label treatment.
Scope of practice for who's allowed to give.
Yeah. I think a lot of that guidance still would need to get hammered out. I think we probably, I do not feel confident that those policies are already in place. And just even a review of it so that it goes in the back here and we know, hey, if it's anthrax, then we do this. If it's Ebola, there's a whole other set of things, right?
Yeah. No, and with the release of the National Biodefense Strategy, they're looking, is the U.S. government writ large, like how can we leverage diversity system, so that
Yep.
was helpful, thank you.
Yeah, absolutely.
Like an implementation plan.
Yeah.
There's an implementation plan.
So as we think about what this integrated source needs to be, right? So what we're really trying to do here, and what you have to keep in mind is these systems didn't exist a year and a half ago. Flu and Call has been around for longer, but the web-based platform is relatively new. And the dashboard, this way of viewing it, this way of communicating it is new. What we now have is this new suite of tools that not just allows us to do the data integration and aggregation, but then also to communicate it out, yes, to CDC, but also back to the states, back to the partners who are giving us those data. And that ends up being really important. One of the most important things you can do when you collect data from somebody is make sure that they have access to the system where you then aggregate and synthesize and visualize those data. And let me tell you, that's not something the federal government always does very well, so it's something that we certainly push hard on, because pushing it back out, making sure that information goes back out to the stakeholders is really critical. But it allows us, in total, to capture preparedness, situational awareness, and response, this full cycle, and actually start to address all of those different aspects of an outbreak or of a response.
The bell's ringing, so we should wrap up.
Yep. And then at the core of it, though, what we're really talking about is simultaneously how can we and how do we use both data science and visualization to support public health and outbreak response? And what does that really mean in practice? Because as I've described, it's not always as straightforward as you would imagine. And the challenges that you're working with are not the kinds of things that can just be solved with an analytical package from R. It's a lot less data analysis per se and a lot more data wrestling. And that's where we end up spending the most of our time, and it's about the data architectures that then support the sorts of flexibility that you need when we don't understand what's going to happen, and when there is a great deal of uncertainty, and when you're working with a messy system. So, there are the key take-homes. That's the system. Any additional questions? Thank you for the questions, Derek.
So what's next with the CDC project? I mean, like you were showing us notional data. When does this all roll out? When does
Right. So the vaccination data, we do actually have real data. I didn't want to spend too much time on it because it hasn't been fully vetted yet, but that's rolling now. The goal is to go live next season on that. Health Pulse, the alert systems, we are working on getting those Sentinel facilities now. So the goal again would be live by next fall if we can. Even if we have very sparse data, again, it's better than zero data.
Right.
And then Flu and Call is fully active live and can roll at any point, but as I pointed out, it only gets turned on in an emergency, so presumably the next 17-18 flu season, it will get turned on. It's certainly ready to do so.
Cool.
Yeah.
And the second one would be hospitals.
Yeah, the alerts, Health Pulse.
And that's not specific to flu.
No, it's designed around flu.
But
It certainly doesn't need to be. It's obviously the most nascent,
yeah, because
for lack of a better.
Thank you.
Yeah, absolutely.
Yeah, I think Monday, TIFA is doing its release of its new Ready or Not report on domestic preparedness. It'd be kind of neat to see like what they're, at least what in the past years they've looked at indicators of beds and some of the stuff that you're looking at specifically for influenza, and it'd be kind of neat to see where those line up right now.
Absolutely.
So just trying to pull up to see if it's out yet, right? The actual release is on the Hill on Monday.
Nice. Probably good to come through.
Thanks for coming.
Thank you so much.
Thanks.